So let's discuss about the direct ophthalmoscope. I am not going to discuss about indirect ophthalmoscope, definitely principle, uses and procedures. So let's discuss. So basically type of ophthalmoscopy what? Uh, in case of direct, we sometimes call it distance direct definitely, and direct and indirect ophthalmoscopy. So distance direct means it's very simple. So performance before direct ophthalmoscopy. So from the distance, certain distance, the light is thrown to the patient's eye, sitting at the side dark, semi-dark room from the distance about 20 to 25 centimeter and features the red glow as the pupil is noted. If red glow are different, then we can think very different things. Like for example, for application, if diagnosis in the opacity of refractive media and seen with a black shadow or red glow or location determined by the motion of parallax, isn't it? So basically that, and pupillary plane remains stationary. This is the I think this concept you must have heard about it before. The concept is basically motion parallax. If you fixate on the pupillary plane, then in front of the pupillary plane anything is there, then that opacity moves against the motion. And if you focus on the pupillary plane, then behind the pupillary plane, suppose this is pupillary plane, behind the pupillary plane is there, if there is anything and which creates shadow, that shadow will definitely move with the movement of our head or along the ophthalmoscope. So that's basically paralytic displacement, which is basically opposite direction in front of the pupillary. If we focus on the pupillary plane, then in front of the pupillary plane opposite direction, and behind the pupillary plane is same direction if opacity is lies. So we can find out at least location of the opacity. Okay. Another, to differentiate between the moles and holes of the iris. What do you mean by that? If there is a hole, then there will be red reflex, that is retro reflex, isn't it? So to recognize the detached retina or tumor arise from the fundus, isn't it grayish reflex? So whitish reflex, for example, what do you call that? The whitish reflex from the suppose, for example, it can be there in case of cataract. It can be there in case of what do you call that? I forgot that disease in the retina. Okay, let it be for now. And then direct ophthalmoscopy. Direct ophthalmoscopy is the most common method of examination, a routine eye examination, preferably done before the dilatation. Yes. So this is the ophthalmoscope. As we know, the viewing hole is there, and there are a lot of things like focusing ring, where we change the power, focusing indicators, and thumb where we put thumb, and basically these are the filters, which is very useful, isn't it? Isn't it? Green filter, cobalt blue filter, slits, and small pinhole, and there are a lot of things. So light adjustment, and there are a lot of parts of the ophthalmoscope. It's very important. Basically, what is the principle of the direct ophthalmoscope? Principally, it is made by the two things, isn't it? One, illumination system, another is observation system. Illumination system means the light throwing system, light source, condensing light, reflecting mirror, and the series of apertures, which is basically illumination system. Observation system, peephole and blank spherical lenses that helps to focus that light from the patient's eye. So basically, modern indirect ophthalmoscope, direct ophthalmoscope work on the basis of principle of glass plate ophthalmoscope introduced by von Holmes. The light from ophthalmoscope strike to the patient retina, and patient retina work as an object, isn't it? And it is reflected diffusely in all direction. So each illuminated point serves as a source of the light. So basically, patient's retina. Suppose here's the light from our ophthalmoscope. This is patient's retina. Then light diffusely come everywhere, and we are here as an optometrist. So we hold the ophthalmoscope, and then this light we focus on our retina, isn't it? The same thing. So emergent rays reach to the observer's retina, that is optometrist's retina, through the viewing hole of the ophthalmoscope, isn't it? So basically, this is the concept. So emerging light, we throw the light from the we throw the light to patient, and patient's retina serves as the object. Now light coming from patient's retina come to our eyes, in optometrist or ophthalmologist eye. Okay. So emergent ray from the emmetropic patients are parallel and brought to the focus, and the emmetropic observed with the accommodation relax. However, if the patient or examiner are not emmetropic, that's the case, isn't it? What we do then, if either is not completely relaxing accommodation or examination, patients fundus clearly, Then what we'll do, we interpose the lens, then we put the lens between patients and observer to correct the accommodation or to correct the patient's refractive error or correct the observer's refractive error, no matter what, isn't it? So this is the basic system. The light from condensing lens and from the prism it passes to patient's eye, and patient's eye reflected by the retina, and now it works as object, and the light coming from that object comes to a correcting lens and then to the observer's eye, the optometrist or ophthalmologist's eye, isn't it? So in hyperopia, patients rays so can be brought rays are divergent, so can be brought by focusing observe. See, I think you guys know this concept, isn't it? If someone is, suppose example, let's take it. Wait. Let me make you clear this concept. Let's take example. Let's take example. Someone is imetropic, then light coming from the patient's eye is always parallel, don't worry about it, okay? If someone is hyperopic, light coming from their eye, exiting eye from the light, like from retina it is tracked and coming back, will be hyperopic. In case this case divergent, don't forget. In case of myopia, light coming from exiting from eye will be converging. That's very important. Even in case of doing subjective objective refraction, that's the very whole key, okay? Just remember this concept. So in myopia, emergent rays are convergent, so can be brought focus by concave lens. That's why in case of myopia we put minus lens in ophthalmoscope. In case of hyperopia we put plus lens. So characteristic of image formed, what will image is always erect because it's virtual and definitely magnified, isn't it? Field of view is smaller field of view compared to indirect. Field of view is approximately 6.5 degree, but it's definitely depend upon many things. So one pupil of the and another pupil's eye, another patient's retina, even axial length. So there are a lot of things that matters, okay? So what affect the size of observer's axial length? So it do affect, and the distance between observer and patient, that really affects the field of view. So okay, so it's not a big deal. So then magnification. So basically, why magnification 15 times? That is always a question. Just see. Don't worry about it. It's very simple. Eye itself has a power of 60, and eye act as a simple magnifier. Simple. Then we have this what do you call it, called formula F54. It's always there. If 25 centimeter is a least distance of distinct vision, then 60 divided by 4 is always 25 times. If we talk about myopia, then definitely power goes higher and magnification goes higher. And if we are talking about hyperopia, power goes down, then magnification goes down. That's why in case of hyperopia, we see crowding. We can sometimes we feel it's like edema, but it's actually not, because of the crowding of the structure, because of the minification. And in case of myopia, we see a large disk, isn't it? Because of the magnification. So it's that matters. Magnification is always asked in the viva. Just tell your faculty that I acts as a simple magnifier. But so advantage and disadvantage of the direct ophthalmos. Let's talk about disadvantage first. No stereopsis, and that's advantages of disadvantage of this direct ophthalmoscope. And when you talk about the indirect ophthalmoscope, that's the advantage, stereopsis. And this is the disadvantage of direct ophthalmoscope. At the same time, this is the advantage of indirect ophthalmoscope. So effect on refractive error and accommodation. This is the disadvantage of direct ophthalmoscope. At the same time, this is disadvantage of direct ophthalmoscope. At the same time, this is advantage of indirect ophthalmoscope. These three disadvantage in the direct ophthalmoscope. These three becomes advantage, or in case of indirect ophthalmoscope. Oh, what are the advantages? Easy to handle. My goodness, it's so easy. Erect image easy to interpret. It's always there. In case of indirect ophthalmoscope, you have to rotate the file of your patients. Magnification is high, definitely. Can be done on dilated, which is the most important. Okay, and multi-purpose we can do use for other purposes. Let's discuss about that. Okay, So multi-purposes. For example, pupillary reaction. You can use, isn't it? For the pupillary reaction, check pupillary reaction. Direct ophthalmos in direct ophthalmos, definitely. For objective refraction, how? See, light ray reflected from the imetropic ray, retina are accurately focused on the retina imetry. If they do not occur, lens of the ophthalmoscope gives the minute fundus deceleration is spherical, isn't it? Suppose you know your power as an examiner, then you wanted to see patient's eye, then you feel blurry, and whenever you change the dial, then can see clearly. At that point, you know patient has refractive error, and you can grossly take an idea it's how much minus or how much plus, isn't it? So objective refraction a little bit, but not that accurately, but yes, definitely. Optical clarity, isn't it? It's very simple. If there is something in the media opacity, you will know from the ophthalmoscope. And dark and semi-dark spots in the red oplex, if no reflex, whole field dark gray and total opaque lens, hemorrhage of the eye and total RD, you can definitely distinguish them. Centric concentric rings on the pupillary area, subluxated lens, you can see that, isn't it? Gray patch in the RD or other things in tumors, yes. Examination of ocular anatomy, isn't it? From cornea, lead, isn't conjunctiva to lens. Yeah, definitely you have to change the focal power of the direct ophthalmoscope, but you can see, isn't it? Plus 20 is used to view the cornea. And when you can put fluoresce into the patient's cornea, and then you can view from the blue filter, isn't it? Lenses between, sometimes between this and this, and anterior segments or vitreous from this power. See, we can see all the things. Okay, one of the great use of direct ophthalmoscopy is visuoscopy in case of microtropia, in lot of case, in case of orthoptics case, especially eccentric fixation diagnosis. So small aperture in a half moon, there is a aperture like a small aperture in a half moon. When do you use? The pupil is minus, or in case of media opacity, there will always be like this is the large, this is small, and this is very small, or sometimes this kind of D-shaped aperture, and this two aperture used whenever pupil is small or media opacity. So basically, what it does, limit or eliminate the reflection from cornea and media. So there is slit beam, always very helpful in to see the iris and retina. If there is any hole you suspect in hole in the iris, then you can use this slit beam. Okay, red free filter, isn't it? That's very good, because to view hemorrhage, whenever we put red free filter, then hemorrhage red thing is just red thing looks black, isn't it? That's the red free. So one of the funny story that a lot of optometrists tell each other, if optometrists are protanopic, then they don't need red free, because protanopic means it's always red free, isn't it? So that's quite in comedy. So also increases the contrast of the blood vessels against the wire and helpful for the oral diameter and nerve fiber layer dropout, isn't it? In case of glaucoma case. So it's very useful filter or red filter. Blue filter is staining. So in case if you go to camp in any other place, it's very crucial for staining the cornea. Okay. So basically procedure, patient is made to sit comfortable. If asked to fix at a distance object and asked to concentrate, even if the head is observed, it's always better patient to say the distance, because pupil is not biased at that condition. Right eye and hand should be used to examine the patient's right eye and vice versa, isn't it? Using large aperture diameter first and external features of the eye is examined, plus 10 diopter, dilated up and red reflex is viewed from the 10 centimeter, and then slowly move towards closer, gradually reducing power of the lens and focusing fundus. Once the blood vessels of the fundus can has been located, then follow it blood vessels up to optic disc. Then systematically blood vessels and four quadrants, general background and macula is examined as step by step, isn't it? So for this is the great reference, and I have seen this, and I think I have take the reference from clinical refraction, but the optics portion is definitely from clinical refraction. Boris, there is a lot of things that optic part I have learned, but this is the great book, clinical procedure and optometry, for this. Okay, so Bistan, choose.